First of all, I'd love to thank Wilson Szeto from Penn. I'm going to ask Dr. Tessa Watt to introduce him, but personally I want to thank Wilson for talking about this very important topic about education and really what I think are our collective missions at leading academic institutions to train the future of our specialty. So, Dr. Watt.
Hi, everyone. Thank you all for tuning in. I'm going to open this grand rounds by introducing Dr. Wilson Szeto. Dr. Szeto is professor of surgery in the Division of Cardiovascular Surgery at the University of Pennsylvania School of Medicine. He currently serves as the chief of cardiovascular surgery at Penn. His clinical interest involves the treatment of thoracic aortic pathology and complex structural heart and valvular disease. His expertise encompasses the full spectrum of interventional strategies ranging from complex open heart surgery to the latest techniques in transcatheter and endovascular therapies. At the University of Pennsylvania, Dr. Szeto remains extensively engaged in the clinical trial research and education of thoracic surgical residents. He's been active in multiple clinical trials involving both endovascular stent graft therapies for thoracic aortic pathology, as well as transcatheter therapies for valvular disease. From an education perspective, he's been involved with the development of an advanced integrated training program that emphasizes the integration of catheter-based interventional skills and conventional cardiovascular surgery, preparing surgeons for the future. So thank you, Dr. Szeto, for coming and speaking with us today.
Well, Dr. Watt, thank you for the introduction and thank you for those kind words. And I want to say to Dr. Aluwadi and the team in Michigan, it's certainly a privilege and an honor for me to be here today. Dr. D, when you called me a couple of months ago, I was very excited. So thank you very much. I am going to share my screen. I apologize in advance for maybe some of my lack of tech savviness, so bear with me, please. Okay, I was told to share this as a first slide for the QR code. So I was told by Tammy to leave this on for a few seconds. And when Mike called me over the summer to talk about potential discussion topics for Grand Rounds, one topic that we discussed was about thoracic surgery education. And I do think it is important for us to talk about this. And as my title suggests here, I think it is a priority for our future, for our patients, for our specialty, for our trainees. And I think this will be a very important and also a fun discussion to have over the next hour. Here are my disclosures in relationship with industry. Just a couple of acknowledgements and recognition early on. These individuals you see on the slide, Dr. Cervasco, our program director for our training program, our two residents, integrated residents in our program, Dr. Kelly and Dr. Hahn, and Mr. DiStefano were instrumental in providing me with some of the content. So I want to recognize their help and assistance in putting this talk together, because it does reflect a Penn approach, or at least our culture of how we think we should be educating our future trainees and colleagues. Also, I want to recognize the prestige that I am currently bestowed upon by speaking here. This is a nice piece written by Rich Prager a few years ago. Michigan is a historical and just a prestigious institution. And I hope you learn as much from me as I will learn from you today in a very nice bidirectional conversation. So it truly is an honor for me to be here today to be speaking on you on this topic. And for the residents, I would highly suggest that you read this. It is a tremendous piece by Dr. Prager regarding the history of the program, and I really had a good time reading about it. So to get started, to put things in a context, as I thought about this talk and when I spoke to Dr. Deeb over the summer, this was a unique experience for me. I've been often asked to talk about aortic surgery, clinical trials data. This is one of the first time I've sort of stepped back and reflect on education. I'm not an education guru, so please be kind to me on this first time giving a talk such as this. but I want to put things into context. I do think there are multiple priorities in cardiac surgery today, and you can see them highlighted here. I do believe cardiac surgery has had a prestige over time. There is a certain, brand or mystique about our specialty, and that's well deserved. So we need to uphold and continue to improve what I think of as the brand of cardiac surgery. We also need to embrace technology and innovation. The world's changing fast, and for us to remain a leader in the space of medicine and for our patients, I think we have to be open to changes. And finally, I think as this global multidisciplinary team approach to patient care has continued on its momentum with new technology, I think cardiac surgery in the space of cardiovascular medicine, we need to continue to be a partner and a leader. And I think education is what ties all of this together. And I think that's why it is such a priority for us to be educating our future colleagues. Just some context again, let's look at our current state of cardiac surgery. What are some strengths and opportunities? I think it is an absolutely tremendous field. I love what we do. I'm passionate about cardiac surgery, but there's so much now for our trainees to learn, both from transcatheter procedures, off-pump coronary surgery, aortic surgery, robotic surgery, structural heart, the list goes on and on. So it's extremely exciting, but the challenges of training our residents to be ready to be a independent surgeon is a challenge. This was a nice summary, I believe. And again, I would recommend the residents to reading this. Recently, John, you couldn't mind us using through the adult cardiac and vascular surgery workforce, did a survey looking at our membership, our practice, and what the scope and what the current state of our profession is. I think it was relatively optimistic. Stable operative volume. Most physicians were either extremely or very satisfied with the profession. However, challenges remain, and I think together we can address them. The length of training, which we'll talk about in a little bit, the educational debt, which I'm not going to get into, but we all know medical school is getting more and more expensive as training becomes longer, workforce shortage, and of course, the burnout depression rate in life-work balance. I'm not going to get into that really. I'm going to focus on the training piece, but I think this does put things into perspective as we talk about what we need to accomplish as a group as we move forward. Now, getting a little deeper into our training programs, I was able to take a look at our data through the NRMP, or the National Residency Matching Program. This was given to me on behalf of Mr. DeStefano, our coordinator. This field of ours remained extremely attractive and competitive. I think that is exciting. This is a snapshot of the last 5 years of an integrated I6 program. The match rate was near 100%. But you can see here is extremely, extremely competitive. 4 applicants per 1 position, approximately. And that's great. I think our goal a few years ago to reinvent our educational program to attract the brightest of the medical students is working. So I'm excited to hear that. The traditional program, the 5+2, similar trends you can see here over the last 5 years. The ratios aren't as high, but it's equally as competitive, about 1.4 to 1.5 applicant per position. And you can see here, more applicants than positions. So again, competitive. So again, I think it speaks well for our future and our pipeline. However, I found this extremely interesting. I got this from Dr. Cervasco as we were talking about how to prepare our trainees to finish and obtain certification of American Board of Thoracic Surgery. You can see here, there remains a steady, approximately 25% fail rate on the oral boards over the last 5 years. So I think clearly there's an opportunity here for us to improve on. I think this is still relatively positive, but again, I think this speaks to some opportunities as we think about how we best train our residents. As I mentioned earlier before, lots been published on the realm of education, and I do not have an advanced degree in education. I don't pretend to be an education guru. But I think clearly this has been an important area that I think especially has understood to be important. So today, for the rest of the talk, I'm just going to talk to you to give you a slightly different perspective, how best to train our residents and fellows from a perspective of me, a practicing adult cardiac surgeon, a simple guy who just likes to come to work and operate and work with residents. So we're not going to get too deep into any of the education sort of theories and education hypothesis, but a bit more of a sort of personal reflection of what I think we do well here at Penn and what some opportunities are. So first, I think it is a culture. And culture, as many of you know, takes time. It takes time to cultivate and improve. I think here are some 3 tenets. I think there has to be a genuine commitment and expectation to education. Every day you wake up, you go to work, expecting that there is that commitment bidirectionally, both from the faculty as well as the resident. I think you cannot forget the pursuit of clinical excellence. And I think the last point I think is really important. It is an environment that you want to create, not of only mentorship, but I think collegiality. And I'll get to that in a little bit. But I think that those are 2 important, I think, concepts that I've really taken home from my mentors over the last 10 to 15 years. To get a little granular, just to give you an idea here what we do at Penn, we have 2 tracks. I know there are currently 3, the I6, the 4.3, and the 5.2. We currently have 2 programs here at Penn, I6 and 5.2. You can see here, this is just a broad outline what we have put together for I6. This continues to evolve, is an experiment in progress, but I think we have done a lot of fine tuning compared to where we were just 5-6 years ago. You can see here that early on, the first 3 years, we have a focus and more of a broad physician, an introduction to many of the skills that I think is important. We offer our residents 2 years hiatus between the first 3 clinical years and the last 3 to pursue additional interests, such as research, or what we call an enrichment program, such as advanced degree in public health or biostatistics, for example, or even basic science research to pursue a PhD if so desire. Year 4 and 6 is our core heavy clinical rotations where we do our best to get our residents to be competent, independent surgeons. Snapshot of what we do here. You can see the majority of the I6 program, to be biased, is cardiac heavy. Majority of the times are spent at our 2 major training programs here at Uphold and Presbyterian. And you can see here the breakdown. But I think what's interesting is we understand the importance of other skills, and we'll get to that in a little bit, spending time in the cath lab, spending time in our CCU and imaging to make a well-rounded cardiovascular specialist. Our traditional program, I think, is also as strong, however, obviously more impact, more compacted. This was the program I went through 15 years ago, a traditional 2-year period after general surgery. You can see here, very traditional, but to be very transparent, very compact, and remains something that we can continue to work on and improve. And I'm proud to say that over the last 10 years, and you can see 2 esteemed colleagues bookending the list, top and bottom, who are now on your staff. I'm so proud of these graduates. We really believe in training and placing our graduates in a place where they can succeed. And I'm just so proud of both Dr. Kim and Dr. Fukuhara. I would argue and be very comfortable in saying that they were strong additions to your staff. So I'm so pleased to have seen at this list of very accomplished resident trainees of ours, and I'm just so proud of them. Okay, well at Penn, what do we do? I know there have been some myths around education. It takes too long to train a resident. It is not safe. The most complex cases, they're just not ready. And I think there have been multiple publications out there, and I'm not going to belabor the point, but I do think training can be safe and conducted in the right way. So how do we train residents today, and how do we become better teachers? And I think that's really the goal of all of us in education. So taking a little bit of a tangent slide here. And when Mike called me to talk about this topic, I wanted to take a step back and reflect, and I did some homework because I wanted to give a little bit of a different perspective. As I was thinking about what are some of the impactful educators or teachers in our time, given my obviously Asian background, I went and read this text, and I would recommend to your residents in your, of course, free time, which is not that many. I think this is an interesting read, an Analect of Confucius. In again, taking things into context, 5 virtues of a gentleman. In those days, 2,500 years ago, gentleman meant scholar. So I want to put that in the proper context. But this applies to everything that we do, I think, in general. What are the 5 virtues? Benevolence, I think it was something that he rated as one of the top virtues. And I think that's absolutely right. Kindness, righteousness, doing the right thing, trustworthiness, integrity, proprietary, duty of respect, and of course, wisdom, knowledge, experience, and judgment. And I think his sort of the way, the truth, how do you become a well-rounded scholar 2,500 years ago resonates today to all we do, especially to cardiac surgery. And I think I would add 2 more on my personal reflection: humility and courage. I think as a surgeon in cardiac surgery, I'm often humbled by what a tough field that we're in, how technically demanding these procedures are. And courage, as I think back where I was 15 years ago, the courage that my mentors have to allow me to do some of these operations with them was certainly noteworthy. So I would add those 2 virtues. And I think this sort of gives you the background and sort of gives you in context how I approach, training, education. I think these are some things, these are 5 virtues that I think we want to keep in mind and should strive to. Well, I think this is the part that I really enjoy when I watch and watch a resident progress. I think the key is inspiration. You have to inspire. Watching a resident or a student in anything we teach, you see this progression, and it's so exciting to watch. You see an individual coming in with all the fire in the belly. They want to do something. I think that's the first step. You see that transition to where that resident begins to think, you know what, I want to do it, but I think I can do it. And then when he or she makes that final leap to, I'm confident, I know I can do this operation. To me, that's extremely gratifying. And I think it leads to the point that to succeed, you must make one to believe. And I really honestly, strongly believe in that type of approach to inspiring and training our residents. Well, at Penn, we believe that. We believe in operating components of surgeries or operations, conducts of operation. We know that you don't make a heart surgeon overnight. Reps, reps, reps. And going back to Confucius almost 2,500 years ago, I thought this quote when I read the book really resonated with me. The man who moves a mountain begins by carrying away small stones. And I think that's what we do in cardiac surgery. And it comes from leadership. I've been so fortunate to have such great mentors. This is just some intraoperative photos looking at what we do. Mike Acker, my boss, chief of cardiac surgery here at Penn, going through a sternotomy with Dr. Sperry, PGY1, with Todd Crawford in the back, our chief resident. I think it's a commitment. Absolutely, it may take a little longer, but safety is not compromised, quality is intact, and it builds morale, and it builds on the foundation of one stone at a time. Dr. Cervasco with our first year traditional fellow, Dr. Chung, last year, harvesting Lima, patiently working with her. I think this is just a great sight to see. This is an operative log of one of our recent I6 trainee that just graduated. I think this gives you a reflection of what we try to accomplish here at Penn. You can see here as complexity increases and as his training progresses, you can see, again, one step at a time. Early on, less complex portions of the procedure. Later on, much more complex high-end operation. And I think that's what we owe to our residents in terms of training. Patience and a commitment to a final product that we were all very proud of. Similarly, Dr. Grimm, our traditional program, again, very compacted into 2 years, but same concept, reps, 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 starting off with components and eventually very complex procedures. Baby steps, right? One step at a time. During my sort of research for this talk, as I was thinking about some of the great teachers in our specialty, Norm Shumway comes up. And this was a very nice piece written by Kurt Tribble. And again, I would recommend the residents to read this. He talks about a shift to the left, teaching the craft of cardiac surgery. And this really resonated with me. The ability to not only do the operation and teach from the left side of the table, but it's a mindset of a faculty as he or she matures from a surgeon to a teacher. Very, very insightful. And again, I would recommend, if you have time, to read this. And again, we at Penn embrace this concept. You can see here Joe Bavaria working with our aortic fellow, doing a complex thoracic aortic surgery. Similarly, me working with a traditional fellow with structural heart surgery. The culture expands, and it is now permeates throughout our program. Senior residents are teaching younger residents. Notice the shift to the left side of the table. And it is really exciting to see what has transpired here over the last 2 decades. I think we also need to understand, as I mentioned earlier as one of our priorities, that we have to embrace technology and innovation. Training isn't just teaching a resident how to cut and sew anymore. We have to think about not only team approach of how we take care of patients, we also have to think about how we train residents in a team approach fashion. Time in a lab, time in a hybrid integrated program, picking up endovascular or transcatheter skills, robotic or minimal invasive skill sets that we may be able to learn from our non-cardiac surgery colleagues, such as GYN, urology, or general surgery. You can see here, Dr. Williams working with one of our residents, Dr. Kelly, training him to do TAVR with our interventional colleague, Dr. Lee, in a hybrid room doing a TAVR. And this nice piece by Dr. Pelletier, when he was in Boston, talking about how do we go from sutures to wires, this evolving necessity of training. Again, a very nice manuscript that I would recommend all of you to read. And again, I think it's a change in paradigm of how we think about training, understanding the evolving landscape in front of us in our near horizon. Something I need a lot of help with my residents, but education in a new era also is no longer textbook. This is the way I grew up. Social media, virtual platform, very video-based platform and training needs to be embraced. Simulation, for example. I'm going to show you a video. And again, this is purely on the excitement of a resident. This was a video, an initiative put together by our trainees about how to best prepare themselves in the OR. This is all resident driven. I'm going to show this 1-minute video.
Cardiac surgery requires immense technical skill. We believe that dedicated practice outside of the operating room can improve surgical skills and enhance intraoperative learning. Our do-it-yourself simulator uses a shoebox to represent a median sternotomy, inside of which interchangeable modules simulate different components of cardiac surgery. We have designed several modules, including the basic skills module, which allows the trainee to practice linear suturing, needle angles, and knot tying. The cannulation module, designed for practicing the steps of aortic cannulation, right atrial cannulation, placement of a left ventricular vent in the right superior pulmonary vein, superior vena cava cannulation, and inferior vena cava cannulation, and the coronary anastomosis module, designed for practicing the distal anastomosis of graft to different coronary targets and the proximal anastomosis of graft to aorta.
Again, this is not high-end work. This is a shoebox and a couple of pairs of gloves, and you can see the initiatives that our residents have taken to do this so that they can continue to be a better technical surgeon and prepare for the OR. For me, it was just a great sight to see what initiatives they had. And I think it speaks to the culture of wanting to continue to be better and be the best surgeon they can be. As I was reading and thinking more about education, another great educator, Socrates, all of you know who he is. I thought this quote really resonated with me. I cannot teach anybody anything. I can only make him think. And I think at Penn, we embrace that as well. We encourage our residents to think on their own, just like they put together that simulation on their own without a whole lot of faculty involvement, but just some guidance. We encourage our residents to think scholarly. This is a record of what they've done over the past 7 or 8 years in sort of publication and presentations. We recently also looked at what other potential opportunities of mentorship we can provide as a specialty. This was a nice publication recently in 2021. Dr. Sultan, one of our past graduates here, really wanted to see the impact of our TSF Foundation Research Awards. And you can see here, no surprise to anybody, it really is a strong foundation to getting our young leaders going in terms of future funding. Very, very impressive, again, documentation of how just a little bit of encouragement and some promotion will go a long way in training our future superstars. I recently was interviewed by one of our Penn Medicine News editors talking about education. I highlighted how important our training program is for cardiac surgery. I try to instill upon our residents and through this journal that training, life in itself, is a journey, not a destination. And as I've said to many of my residents, you are my resident just for a brief period of time. You will be a respected colleague of mine for the rest of our careers. Hence the importance of not only mentorship, but collegiality. And I really believe in that. And finally, I just love this photograph. The student becomes the teacher. Mike Ibrahim finished graduating just in July. He told me, you know what? I want to do Ross procedures. I supported him. We sent him up to Mount Sinai to work with Dr. El Hamazi. He returns to Penn, and in August, he does his first 2 Ross procedures. And I learned from my student. So the student becomes the teacher. And to me, cannot be more gratified than seeing a young surgeon that I've seen since he was an intern to progress to a competent, mature heart surgeon. So to me, that is absolutely gratifying. And finally, I want to recognize the mentorship and the leadership at Penn. This is one of my favorite photos. There have been 4 chief of cardiothoracic surgery at Penn. Julian Johnson was the inaugural. You can see here, this is a photograph of my mentors, my colleague, and I would be proud to say my friends. The 3 alive previous and current chief of cardiac surgery, Edmonds, Gardner, and Acker, and of course, my good friend, Joe Baveri. I've learned so much from them. And it is, I think, a testament to why Penn is such a special, special place. And I want to finish by showing a video, sharing with you. Again, this was initiated by residents. As these residents now have really embraced our training program, Dr. Kelly and Dr. Hahn put together this video for our resident applicants to give them a flavor of what we do here at Penn. And I think this would be a nice way for me to summarize this talk and show you how proud we are of this program and what some of our faculty, as well as me, think about what we do here. So this is about a 5-minute video I'm going to show.
At Penn, you learn by doing. There is no program in the country where you will get as much hands-on experience, as you will, in our program.
Penn Cardiac Surgery has multiple missions, but training residents is one of our most important endeavors. Penn is certainly, in my opinion, one of the top training programs in cardiothoracic surgery. I certainly think what sets this program apart is not only the exposure to the complexity and the full breadth of cardiac surgery, but also exposure to top-notch faculty, renowned and recognized internationally.
As a recent graduate from the Penn Cardiac Surgery program and new faculty member, I can say without any reservation that it is the best place to train to become a heart surgeon.
I believe that the training program is incredibly broad. We have expert heart transplant, VADS, heart failure. We have a very large thoracic aortic service. We have a very large experience with ischemic heart disease, coronary bypasses. We have excellent endovascular and endocardiac experiences. This includes TAVR, transcatheter mitral valve, structural heart, as well as advanced TVAR and thoracic aortic procedures, which are the procedures of the future.
Penn has one of the largest cardiothoracic transplant programs in the country. You will be exposed to heart transplantation, lung transplantation, and heart lung transplantation in large volumes. We perform a large number of ECMOs and ventricular assist devices, which you will be exposed. From the very beginning, you will be on the right side of the table, doing cases with the attending on the left side of the table. That is our DNA.
The fact that no matter how complex the case, no matter how technically challenging it is, the expectation and tradition is that it is done by residents.
The most important thing in cardiac surgery training is 5 words: right side of the table. Surgery takes reps and experience, and being on the right side of the table is paramount, and that is the rule at Penn Cardiac Surgery.
In addition to the operating rooms, you will learn by doing in our intensive care units and in our clinics.
I think the great thing about working in the ICU here is that you get to work with a collaborative team of people from multi-disciplines that are interested in taking really great care of patients. We take care of a really complex patient population, and very quickly in that process, you feel comfortable taking care of these people.
In the middle of our residency training program are a minimum of 2 years of academic development time that you can really tailor to your own interests, whether they be in traditional basic science, in public health or outcomes-based research, in global health, or even in ethics and education.
And finally, you should come here because we are a family. We have fun coming to work together.
The Penn Cardiac Surgery program is so responsive to all of its residents. And over the last few months, I've learned that as my program director and the team have worked with me to structure my maternity leave and my clinical rotations when I come back full-time in July. In this way, the program has really helped me meet my goals of having a family and being an outstanding surgeon.
One thing you can't forget is that becoming a cardiac surgeon is not a solitary pursuit. The amazing reality is that you're going to spend more time with these co-residents growing into surgeons than you have with friends or colleagues at any other stage of your careers. You're going to discuss research ideas with them. You'll be inspired by them as they're inspired by you. You're going to find them to be your intellectual equals. You're going to spend time with them outside of work. You'll go to their weddings. You'll travel with them. You'll meet their children. You're going to take care of patients with them late into the hours of the night. And these amazing bonds that are formed and growing into doctors together will persist well beyond the duration of your training, frankly, for the rest of your lives and your careers.
Looking back, the training of all of these fellows is my greatest accomplishment professionally. Your destiny is our destiny.
At Penn, we're really old school program. And by that, I mean, we work hard, we enjoy working hard, and it's all about our patients.
And again, that was put together by one of our residents, and really is gratifying to see, for me to see that they truly believe in what they do and they are passionate about what they want to do. And I'm just so proud to be part of that whole pursuit, and so proud to be part of that here at Penn Cardiac Surgery. So thank you. And I look forward to more conversation and learning from you and the team of Michigan. Thank you very much.
Thank you, Wilson. Love to open it up for questions from my colleagues and our team here at Michigan. That was a fantastic talk, and loved all of it, and hearing about your culture, your approach. So I'm gonna first start. Maybe I'll start with a question. You know, in an era, and I know your team is very focused on clinical outcomes, as is ours. Tell us a little bit more about this transition to the left side of the table, and how does your team employ that with some of the sickest and most complex patients that you treat in Pennsylvania and what we treat in Michigan? Tell us a little bit more about how is that taken? What if things get tough? Very critical parts of the operation. Maybe give us a little more insight on that.
I think that's a great question, Gaurav. I mean, that's your constant, challenge in the balance between education and quality and outcomes. I don't necessarily believe they're exclusive, mutually exclusive. But you're right. There will be situations where a more senior resident or a more senior surgeon is more appropriate to do a certain portion of the operation. I think I would be naive to say that every portion of the operation is done by a resident, because there are going to be points where a senior surgeon needs to step in and address the issues. Having said that, I still think that can be done in a very educational manner, where the resident still has value of being there and learning. As you know, as the senior resident becomes more and more senior, they don't necessarily have to throw every stitch. As long as they understand the setup, they understand how to expose a particular portion of an operation. I think there's still a lot of value to education. In terms of quality initiatives, which we've been a huge proponent of here, as you know, we've had conversations about it. It's a commitment. I think the culture of, a senior surgeon downstairs drinking coffee while a senior resident is doing most of the cases unsupervised is probably a thing of the past. Not probably, is a thing of the past. And I think it takes a commitment on the faculty part where presence and guidance at the table will ensure quality. So it's a balance. I don't know if there's a perfect answer for that, but I think it can be done. It's our belief here at Penn.
Hey, well, Wilson, this is about a great presentation. I was expecting you to talk about something aorta, but you choose it.
It was hard. It was hard for me not to.
Anyway, so my question for you is, how many cases do you guys do in your program? The whole, couple thousand, and what of those cases? How many cases did the resident participate, or did the PA participate? And do you guys have any surgeons just work with PAs, or surgeons want to work with residents?
I think that's a great question, Bo. I think the majority. Well, I'll answer the first part. What we consider major cardiac cases, meaning cardiac cases, maybe what I mean by that is cardiac cases that have educational value. So it includes pumps, it includes TVAR, it includes TAVR, because we believe surgical residents should do TAVRs, ECMO. It's about, at our two main training program, HUP and Presby, it's about 1,800 at HUP and about 900 at Presbyterian, so about 2,700. there are 2 other hospitals in our health system that do heart surgery with no residents. So looking at the core 2 hospitals that train, I would say over 90% of those cases are covered by a resident. We're fortunate that we have a large training program, that we have enough residents to cover the cases. So rarely will a case go uncovered, but it does happen. But it's important for us. We think a resident, I think there is a value to every case that a resident can be exposed to.
So if the resident is not, if the case is not covered by the resident, the surgeon does it with another surgeon or with the PA?
Usually with a physician assistant.
Yeah.
But that's rare. That's less than 5% of the time.
So you have so many residents who cover all the cases. How many residents do you have?
We have 2 traditional. We have between traditional and integrated I6. There's 3 per year. So if you do the math, I think we have. So if there are 6 residents I6, 2 residents I6 for 6 years, so that's 12 right there at any one time.
So you have
so that's
you only have
12.
3 chiefs per year, right?
We have 3 chiefs a year.
So you don't go to cardiac, you don't go to thoracic, you don't go to P's, they all stay without the cardiac?
No, they do general thoracic, they go to CHOP. But we also have, we have advanced fellows too. We'll have 1 or 2 aortic fellow, and we'll have a transplant fellow.
Okay.
But we are also in many ways flexible in the way that a case is covered. Ideally, a resident is in the case from beginning to end. But if there is another case ongoing and the critical portion of the case is over, guess what? Me as the attending, again, this speaks to commitment to education. I will tell that resident, I will close with the PA. Why don't you go to the other room and do the other case? So it's a commitment, it's a culture. I want my residents to have exposure to cases. They're not there to close for me. I'm here to educate them.
Wilson, that was a spectacular talk.
Thank
you. I think maybe a couple of things. First, thanks for coming to our grand rounds. Second, thank you very much for sending 2 spectacular faculty members to join us here at Michigan. They have enhanced our brand quite a bit. Thank you. So I have a question about selection. I'm curious what Penn looks for in a CT surgery applicant and how you go about making the selection for entry into a great program. Thanks again.
Well, Himanshu, thanks for those kind comments. And I would agree with you. I think Karen and Shinichi are just spectacular, superstars. I'm so proud. As part of the selection process, we have obviously all the residents come through an interview with the faculty as part of the interview day. I think there's just some general broad categories. Obviously, individuals who are passionate about cardiac surgery, individuals, cardiothoracic surgery, let me rephrase that, individuals who have demonstrated a record of excellence, meaning they're willing to work hard. We want residents that work hard. And we also put a lot of importance on collegiality. We really would prefer students or residents, depending on which program you're talking about, that we think will work well and not compromise that culture that we've built over the last 2 decades. Someone who is willing to work together with his colleagues or her colleagues, someone who's willing to be humble and listen, a well-rounded individual. And then of course, we want a diverse group. We do not want the same individual from the same program over and over again. So I think diversity and different ideas are important. So in broad category, that's what we look for. We look for a person that, in my opinion, in 6 years, if there is an opportunity, we would bring on staff. I think that's kind of the, at least in my perspective, what I think is the ideal candidate. Someone that I can foresee being a colleague in 6, 7 years.
Can I comment something?
Of course.
Yeah, thank you so much for the fantastic talk. This was a very inspiring for our residents as well. Thank you so much. So my question is, I started recognizing, more and more. I think one of the challenges for, CT surgery training program and the residents, is basically just, really long work hour, maybe burnout, mental health issue. I think these are significant challenge. And then when I was a trainee, or when you are training, maybe we are not thinking about this, but I think this is a very important topic. So how do you handle these issues at the Penn? I didn't pay attention to it when I was there, but maybe this is a good opportunity to ask you.
Yeah, that's a very good question, and I don't have all the answers. Certainly, these challenges exist everywhere, including Penn. Work-life balance is extremely important, and I'm probably guilty of someone who doesn't always observe work-life balance. I think Dr. Cervasco, she does a great job. I think is, again, a culture of collegiality and mentorship where I think the residents need to understand that they're supposed, and it's okay, they're supposed to come talk to you when there are issues. I think you need to be supportive and try to understand what the issues are. Whether we can address all the issues, that's going to be individual based. This is a tough profession. And it may not be the right profession for everybody. Attrition is real, but hopefully it'll be rare. But I think it's just having an open door policy, which is what Marissa has, an open door policy that the residents can feel very comfortable speaking to. To be honest, Mike Acker, is a strong patient and strong resident advocate, but he can be intimidating. So I think having a Dr. Cervasco helps in that matter.
I see. Thank you so much.
Wilson, one question. I noticed in your pictures, and just talk about diversity. Most of the people, your resident or your faculty in the picture are men. How many women do you have in your residents and your faculty?
That's a great point. So Dr. Cervasco joined us about 2 years ago. Dr. Maluski, she was here, but she was recruited to Yale about 1.5 years ago. So we had 2 women faculty in a faculty of around 10. So I think we've made progress, but I think there certainly is an opportunity to improve. Right now in our program, residency program, there are 4 women residents, and there are 2 incoming next year that will be women as well. So we're doing our best. We understand how important it is. And I'm proud to say we're making progress. And I don't regret any of these recruits because these women applicants are just spectacular. There are some of our strongest residents. So I think this is a great thing, not only for our program, but for our specialty. Dr. Cervasco is just, I can't say enough good things about her. She's a resident, she's a faculty in 2 years of practice, and she's operating at a level of a senior surgeon. So she was a very, very fortunate recruit for us here at Penn from Columbia. So we stole one.
Wilson, I just wanted to share a little, some of our data, since you mentioned, learning from us. I was surprised, very pleasantly surprised when I was recruited here and looking at the program myself, that the training program, even well before I got here, was about 50% female. So
great, very
concerted effort to, like you said, shape the future of our specialty. And we really hope that will lead into, the changes that we're hopefully trying to employ in the faculty level as well for that greater level of diversity.
Yeah, and we're learning from you. And I think it's absolutely important because it will make us a better specialty. There's no question in my mind.
So Wilson, I have I have first a comment and then a question. I love your Zen, Wilson. I love how the aura of your talk, and I know that's gone into the culture there at Penn, and that's why Penn has that culture of humbleness, giving, everyone focused on doing something bigger than themselves. And I think you are, although you give credit to everyone else, I think you are a huge part and a big component of that. And I applaud you for that.
Thank you.
That's number one. And then I'm going to ask you a technical question about education. When you have a first or second year resident in your room, and you know that they're not capable of doing, the key portions of the case, yet you want them to do the sternotomy. Say you have a second year and you want them to cannulate and everything, and you're on the left side. When it comes time for you to start to perform the operation, do you switch sides or you do it all from the left side?
It depends on the resident and it depends on the case. Believe it or not, many of the aortic cases I can do from the left side of the table. So I've done a type A dissection on the left side of the table with a second year resident. I've done AVRs. I've done cabbages. Mitrals are a little bit harder. So it all depends on the case and it all depends on the resident, where they are progression wise. So I do think all these years of being here and watching Mike Acker and Joe Bavaria, I've kind of, and then on Norm Shumway's spirit, I've learned how to operate from the left side of the table. But it does take a level of comfort that takes a while to achieve. But I have to say, I can do that because we're fortunate to attract very motivated, very good residents. These residents are proud and they want to do well. But to answer your question, depending on the case and depending on residents, sometimes I have to switch, like a minimal invasive mitral repair, a mini mitral through a right thoracotomy. I have to be on the right side of the table. But some of the bigger open sternotomy cases, much can be done on the left side.
I'm talking about sternotomy.
Yeah, absolutely.
So extremely important in the evolvement of a academic surgeon's career, that they evolve and learn how to operate on the left side of the table so that they can fulfill their function as a teacher within an academic community and environment.
Yeah, I mean, and I would recommend most of you to read that article, and I'm happy to share the content of this talk through Tam with your team. Shumway talks about, and Kirk actually, not Shumway, Kirk wrote the article. The best assistant is your faculty. As we all know, sewing, anybody can sew. It's the exposure in the setup. So I do think there's a huge component of being on the left side of the table is to provide the exposure in the setup. And then you can tell the resident, put a stitch here, put a stitch there. And then as the resident progresses to become more senior, then you can demonstrate to them the nuances of how to expose the setup and operation. So in many ways, the myth of the surgery actually is slower when you were doing it with a resident. I would make the argument that I can actually get through a type A dissection faster with a senior resident because I'm exposing and I'm doing things to move the case along. So I think that's the advice I would give is to the senior surgeons and even younger surgeons is that you are a resident's best help. And as a senior faculty, you're the world's best first assistant. There's not going to be a better first assistant than you because you know the operation and you can anticipate every move.
When you hire young surgeons, Wilson, do you discuss with them that it is an expectation of them that they evolve as a academician and that they learn those skills and they become fully comfortable and confident on the left side of the table? And is that a requirement for them for promotion and other things at Penn?
It's not a requirement, but it is a culture here that all of us have bought into. There is no hard requirement. However, there are, we're surgeons, we're a proud group. If the boss does it that way, Mike Acker, it starts at the top. People start to fall in line. And it's a sense of pride that you can teach because it's important and it's our DNA, as Michael said in that video. But no, it's not a requirement. We also understand, however, that I do not expect a junior first year attending to teach at the level of Mike Acker. It does take an evolution of time. And believe it or not, we often have to hold back the enthusiasm of our young faculty. And I would have to pull some of these guys and gals back and say, you're giving up too much. The cases, you're not quite ready to give this case up. You should consider do it with a senior resident or doing some components of the procedure. So I think it's not one size fits all. I think each faculty has to progress at his or her own pace. And because at the end of the day, quality and patient safety is the utmost importance.
Thank you, Wilson.
Thank you.
Wilson, so thank you for these insights. I mean, I think we've all taken a lot from your talk and sharing of your culture. I think it mimics certainly what I have learned and the approach that I and many of others here at our institution take. And it's great to see what a premier training program, how they view the importance of education, training of the future, and even with the highest complexity of cases, learning ways to make the resident a priority. So from all of us at the University of Michigan, I want to thank you for taking time out of your very busy schedule. The offer, of course, still stands to come visit us anytime. And when we can try to arrange around a football game, absolutely for you to enjoy. So thank you again, Wilson. I'm sure the conversations will continue amongst our faculty and as well as with you. And we look forward to seeing you again soon.
Thank you very much. It's a pleasure, and happy to talk to anybody, for conversations. Happy to do so. Thank you. It's been an honor.
Thanks, Wilson, for your inspiring talk.
Take care.
Thanks.
Bye-bye.
Bye.